Hello, and welcome to today's episode of the Pediatric Consult. I'm Dr. Paul Bunch, a community pediatrician, and your host for today's episode. I'm very excited to talk to today's guests, Dr. Nancy Crimmins, an endocrinologist, and Dr. Stavra Xanthakos, a gastroenterologist here at Cincinnati Children's. Today's discussion is on GLP-1 medications. Certainly that has been the top of medical news over the past few years. Been mostly focused on adults, so really wanting to learn more today about how we can use those with our pediatric patients. So Dr. Crimmins, Dr. Xanthakos, thanks for joining me today. First of all, if you guys could introduce yourselves, tell us a little bit about your background, how long you've been practicing, how long you've been at Children's, any interest maybe outside the hospital.
So I'm Nancy Crimmins. I've been here ever since residency and stayed on, and it's been really interesting to see how the field of obesity has changed just since I've been in practice. And for a long time, obesity wasn't even considered a hormonal thing or an endocrine thing, and now we know so much more about the science behind weight regulation, and then we have these medicines, right, which wouldn't even have been on our radar like when I started. So I'm really interested in genetic forms of obesity and early onset obesity, and then just sort of that spectrum through prediabetes and type 2 diabetes, which we use these medications for. Free time, let's see, I love to walk and hike. I love to read, and just I'm an extrovert, love hanging out with people and my friends.
That's great. Dr. Xanthakos?
Hi, yeah, I've been here a long time as well. I did my residency here, just a great place to work, and so never left. I've got interested in obesity during fellowship, and like Nancy said, I think this is a really exciting time because we're really understanding more about the endocrinology, and a lot of it is gut focused, like a lot of it is stimulated by nutrients. So I'm very interested in the nutritional aspects of this, like what foods and activities could naturally kind of reset our GLP-1 systems. But the advent of these new pharmacotherapies is just super exciting because they do really help boost our patients' success.
Great.
I do want to say, too, that Stavra was my chief resident.
Yeah, we go back a long time.
So it's kind of fun that we're doing this podcast together.
It's really nice. Yeah. Oh, and then my outside interests, I like to read as well, but I have gotten into weightlifting in part because I think it does help with your metabolism. And so that's something as I get older, I've been trying to do a little bit more of.
That's awesome. Hiking, walking,
yes.
weightlifting, all good modeling for our patients.
Yeah.
So today's discussion is on these GLP-1 agonists, the glucagon-like peptide 1 agonists. We don't need to get super deep into the pharmacology, but just to set a baseline, can you guys talk a little bit about what these medicines are, a basic review of how they work and why we started to use them?
Yeah, so one of the interesting things about these classes of medications is they've been around for a long time. It's almost serendipitously discovered, but it turns out our gut is really sensitive to what we eat. And so these hormones, are secreted by special cells that are found throughout the lining of our intestine that secrete these hormones that then communicate with local organs as well as the nervous system to send signals to our brain, our pancreas, and multiple other, our white blood cells, like just many, many receptors throughout the body. So they in part were discovered because of the effects of bariatric surgery, and they found that these hormones really shifted. But I think there were also some serendipitous discoveries that of the diabetes improvement. And maybe you can take it from there, Nancy.
Yeah, I mean, to me, again, it's kind of cool practicing this long because the GI system wasn't thought to be an endocrine organ in any way, like when we trained, and now we know that. But these gut hormones are just sort of, I think of them as a signal to say food's in here and helps augment that insulin, release that's going to happen as the blood sugar goes up. So it was first discovered that people with type 2 diabetes didn't make GLP-1 normally compared to people without diabetes. So that was then a drug target for a long time. And it took people forever, like a lot of endocrine therapies, to figure out how to make them therapeutic in the body and last a long time. And so that was a huge discovery. Actually, fun fact, in the Gila monster, there's a natural long-acting GLP-1. And so we actually owe this whole class to this cute little orange and black lizard. But they were brought on board as diabetes therapies first and were very effective in controlling blood sugars. And it was the first time we had a type 2 therapy that was not only weight neutral, which was a huge goal, but led to weight loss and safe weight loss. And even though diabetes is something we're always going to want to make better. We hadn't had an effective weight loss therapy. So then these companies are like, hey, this could have a place, beyond type 2 diabetes and glucose management. And now is expanded into liver and sleep apnea and all kinds of things.
And am I correct in remembering that they were around as like an oral medication for a long time, but it was the change to injectable?
No, the first one was an injectable. It was a twice a day. It was literally synthetic Gila Monster, GLP1. It was called Xanthakos or Byetta. That was the first one to come on the market. Now, it was never approved for weight loss. It was a diabetes medication. But then I think when that formulation finally came out, then these other companies could then further manipulate it to make a daily one, which was liraglutide, and then it expanded. The oral one, which was semaglutide, came out for diabetes first, and now there are oral ones that will be coming. Well, one just did get approved by the FDA for 18 and up, but there are further ones coming down the pipe, or more of them, that will be oral for weight loss alone.
Okay. So obviously it's a very powerful tool that we have in our arsenal now. What are some of the recommendations currently on the pediatric side of when we start to consider a GLP-1 agonist? Where does that fit in the treatment pathway?
I mean, I think for people in primary care, it's obesity, right? Because usually if you have diabetes, you're seeing an endocrinologist. So they're really approved. There's two that are approved for treatment of obesity in children: liraglutide, which is a short-acting daily injection, and semaglutide, which is weekly. And they're currently approved for treatment of obesity in children 12 years of age and older with a BMI at the 95th or greater than 95th percentile, which correlates roughly with the BMI of 30 in adulthood. You don't have to have an obesity comorbidity, but that's the official approval indication for use in weight management.
Okay.
And then I think the other part of that we need to make sure we're talking about is it's in a context of making lifestyle changes.
Correct.
These were never meant to be used as, in a vacuum of not doing that, and having a relationship with a provider who's monitoring labs, monitoring, what other things are going on.
And we'll talk about this, but there's important side effects of these medications that can really change what patients eat. And it's very important to monitor the quality of their nutrition. So that is a really important point to stress, is that the first line shouldn't be the medication. It should really be these lifestyle changes with the medication then added as a booster or adjunctive treatment.
Okay. So in a primary care setting, I mean, how long would you suggest that we work on lifestyle modifications? How strict do we need to be as far as you must follow these guidelines before we even discuss GLP-1s?
Yeah, I think that's the challenge for a primary care practice, is because you really need a dietitian, some sort of dietitian access. So some offices, I think, have that, which is amazing, and have those relationships. I think some have to kind of use either, a large tertiary hospital like ours, or, but that pathway needs to be formed. You certainly don't want the patients, in my mind, going off on their own and, I don't know, TikToking nutritional lines. And then the exercise, I think, is a little easier to flex, because some kids are in sports, some belong to gyms. That doesn't necessarily have to be under the supervision of an exercise physiologist. And but I think there needs to be some sort of plan, again, to protect your muscle and to have those pieces in place that the PCP is monitoring and overseeing before doing. Because
bariatric surgery typically has had very strict guidelines of psychological evaluations and monitored exercise, monitored before that's even an option.
And that's a really good point, because we don't talk about that piece, I think, enough in weight management, the mental health piece, because really that's a part of that too. If you have coexisting depression or anxiety, it's not that you couldn't prescribe those medicines. That's not what I'm saying. But how the body image is seen and bullying and other things might be playing into this drive to want these medicines or to be at a certain weight. And I think there needs to be some evaluation of that as well.
And just also disordered eating, because some adolescents especially, they may be trying things out like intermittent fasting, or they may be doing late night eating, and you really need to understand those eating habits before you put them on a medication that may suppress their appetite.
Okay. And you mentioned, 12 and older, BMI greater than 95th percentile. Are there any other indications that we would be considering, whether it's in primary care or more in your specialty world?
You don't necessarily need to have a comorbidity, certainly diabetes, and they're approved for treatment of diabetes independently of even the obesity. They are not approved yet for any specific comorbidity conditions other than diabetes and pediatrics, but they have recently been approved for some of them. There's different classes of these medications for sleep apnea, for MASH, which is that steatotic or fatty liver disease that we see a lot of in GI, and then also one of them for heightened cardiovascular disease risk. I think there's one of the newer ones that's approved for that indication. So when you get to 18 and up, you could potentially be prescribed these medications for the treatment of specific comorbid conditions.
So when we have these families in our office, and whether the parents or their kids are asking us about these, or we are bringing up that, are there certain points that you want to make sure you hit before we've even started the medications? Advice we're going to give to the families and to the patients about what this experience is going to look like?
Yeah. So, hopefully, again, you've been having some run-in conversation before you as a group decide these medicines or something you want to do. And again, including the kid in that conversation away from the parent, I think is important. I have seen cases where I think the parent wants it for whatever reason, and the child does it. But once you've come to that, I think it's making sure there are no contraindications to being on the medicine, and then giving them realistic expectations. And when I say that, part of it is honestly financial, because not all the insurances cover these medicines for weight loss. And it's hard to you can't just say like any one insurance company is or isn't. It's really company dependent. And so they can be very costly for families. The public insurances have handled it different ways. Different states handle that differently. So I think that's an expectation you need to set up early. And then the monitoring expectation. You're not going to write this for a year and see them later. You want to make sure you're monitoring for side effects and that they're tolerating it well, and that those lifestyle things are still staying in place.
And I think another important point is if they come off the medication, which could be because they decide they don't want to take it anymore, or because their insurance company suddenly changes their policy, there's a very high likelihood they will regain the weight. And we don't fully understand yet, what habits may help you keep off some of this weight loss. And there's probably some things that you could do to help minimize that. But at least the studies I've seen, the vast majority of people that come off end up regaining most, if not all, of the weight they've lost. So it really is, you're resetting your hormones, and coming off that medicine, you're likely to regain the weight. So I think that's an important point that we don't always touch on, which we probably should more. Yeah.
Well, and making sure they have the right goal in their mind. Because I think sort of the American culture is there's a weight, right? Like you want to get to this weight, or you want to look like this. I think it's very human nature to come with those sort of expectations. But really, I think our job as physicians is like, no, there's something about you that makes weight management harder. And I believe that you're clearly trying, your family is trying, but these medicines are really to kind of equal that balance out. And you still need to, be very careful about what you're eating and your exercise habit, but it's really about this healthier lifestyle and making sure you're at least modeling and approaching it the right way, I think, with the patients and families.
I think that's a really important point. So I try a lot not to talk about them as weight loss medications, but more as metabolic medications, because a lot of times we don't see the same degree of weight loss that you might see in some of these clinical studies. Like I might see a child whose BMI has been almost vertically rising, and they get them on these medicines, and for the first time ever, they've been coming for years, we're doing lifestyle, you start to see it plateau or maybe go down a little bit. But some patients lose a lot of weight and others don't. They just sort of flatten out. And so setting expectations that we don't know how this is going to be for you, but we're really doing this to improve your health.
Yes.
And definitely putting it into context of healthy lifestyle changes, increased activity, better diet. So, okay. And then, so like you said, you kind of get a different response depending on the patient. Now, for those who do lose weight, do they just continuously lose weight? I mean, obviously not to nothing, but is it like typically if they're going to lose weight, they lose a lot in the first 6 months and then it plateaus? Or do we see kind of steady continued weight loss? Or
You know,
drop in BMI?
I might let Nancy take this one because we've been using them in the MASH program a little bit less, long than you have in diabetes. So I can't say that I've seen that like we do with bariatric surgery where you hit that plateau and then you sort of are there by year 1. So I don't know if I've seen that pattern. Have you, Nancy, with the diabetes?
Yeah, it's a little bit of a complicated question because in diabetes, just by the nature of the disease, studies show you don't lose weight as easily as you do as if you don't have diabetes. There's reasons for that. But part of it has to do with what dose you tolerate. So the higher you go on the dose, you can have more side effects. And so some people just can't get up to max dosing of some of these medicines or don't tolerate them as well. And then I don't know. I don't have great science to tell you right now. This is my personal belief. I really think in some people, they are truly deficient in this pathway. And it's kind of almost rewarding to see because when you put these medicines on, you will see this pretty rapid weight loss and they do plateau. It's different for everybody after a while. We all do, no matter what we do to lose weight.
Sure.
It just in my head, I'm like, this medicine shouldn't make that much difference, and that's how endocrine works. You're missing a hormone or your system doesn't work well, you replace it and life's better. It's like why I went into this field. So it really is a varied response. And I think that's important to tell people too, because they'll be like, oh, my uncle lost 100 pounds and I've only lost, 15 pounds. Well, there may be different reasons, some that we don't even understand on why there could be those differences.
And that 50 pounds may have made a big difference in their overall health.
Yeah, we know it does. Like small amounts of weight loss of even 5 to 10% of body weight can make a big metabolic impact.
I've actually had patients that don't lose much weight. They just sort of plateau, but they have tremendous metabolic improvement. So that frustrates me when we suddenly are told we had to stop it because they didn't lose weight, because that's technically you're supposed to stop it if they don't lose weight. But as a metabolic treatment, it's great, even if they're not losing weight.
Well, we see that in diabetes.
Yeah.
Like those medicines improve your A1C and improve your glycemic load.
Yeah.
Even if you lose a little bit or a lot, so they do have independent effects.
Yeah.
The scale doesn't tell the whole story.
It certainly does not. Yeah. I think that's what people focus on, unfortunately. And again, I think that's our job to make sure we're putting in the right spot. But
so if we go through all that, we talk about expectations, we talk about, what this is going to be like. And you and the family agree that this is probably the best next step. Are there any screening labs to get beforehand or other studies that you guys typically recommend before we start these medicines? And then once they're on them, monitoring. How do we monitor these kids?
Well, we generally check our cardiometabolic panel, frequently in clinic every, 3 to 6, sometimes 12 months, depending on how frequently people are coming back. So I usually like to have a baseline set of those labs before I start the medication.
And what are those labs? Because everybody kind of does that a little differently.
Yeah, it's usually a fasting lipid profile, a hemoglobin A1C, liver enzymes, ALT is the primary one, but I usually get AST and GGT because that's what we do. And those correlate with improvement as well. Some people will get insulin and glucose, but I'll let Nancy opine on that.
Yeah, I love fasting glucose because if you think about your pre-diabetes criteria, it's based on fasting glucose and A1C and OGTTs, which nobody really does a lot of anymore. But so I think that fasting glucose is important. The Endocrine Society has said quit checking fasting insulins. I see people do it all the time. I actually do it. My little kids, I worry about genetic stuff with once because it's interesting to see if there's severe insulin resistance. But we don't really make any decisions on treating the other comorbidities based on that insulin level alone. And the assays are kind of finicky, so not recommended.
But
so we'll get those baseline labs, which may or may not be normal. If they're abnormal, that gives us extra reason to treat. How often do you then monitor those?
Well, I could tell you what we do in our clinical program, which we're seeing people back essentially every 3 to 6 months. We probably do labs a little bit too frequently.
I think
you agree?
Kill the labs.
I think we overdo it.
Because if they're normal and you're on a GLP-1 and they're doing well, they're still going to be normal. So to me, it's the ones that are abnormal that you need to follow. I think it's reasonable to get a fasting set once a year.
Yeah.
But if your lipids are normal,
it's a bit burdensome on the patients, I feel like.
So normal, like 3 to 6
But it is
months.
nice for families to see improvement.
Yes.
I think more important than that, and I know this is not readily available in most pediatric practices, is we have these bioelectrical impedance assay scales, which are actually not super costly, but they're very helpful to have if you do want to start using these in your clinical practice. I would really recommend investing in one because that allows you to track body composition, which I think is probably way more important to check at each visit than some of these labs that we do.
Yeah, I think both are nice, but what you're wanting, even if you don't use these medicines, in my mind, if you're managing obesity to any degree, is again to pull it away from this number that like everybody anchors on, and to make it more about the fact that you're building healthy muscle and getting your body fat percentage down, right? And so again, if you have a child who came in and the weight's the exact same, but you're showing them that the body composition has changed for the right way, that's I love that.
And the kids
get it. The kids get it. We explain it. So it's not like, what are you talking about?
It's a great talking point too, because if you see the skeletal muscle mass go down significantly, then you have a little bit of an angle to say, hey, this is why we really need to get your body moving and do some more physical activity that you enjoy. So I think it actually, for me, I find that the BIA, I won't use the specific brand, but the BIA machines that we have, which are pretty easy to use, are an incredible tool in clinical practice.
Very cool. You guys have referenced side effects a couple times. What are the most common side effects? What are some other more worrisome side effects we should always be on the lookout for?
Yeah, I'm going to take that as the GI doctor because by far the most common side effect that keeps people from staying on these medicines or going up higher on the dose are the GI side effects. So these medicines, these receptors are found in the GI tract and they slow down gastric motility. So a lot of people feel very nauseated or even have significant vomiting, especially in the first day or two after the injection, if it's a weekly injection. So that's why it's very important to start at a low dose because it does typically get better in many patients. But there are some that are exquisitely sensitive to this side effect where they can't even handle the lowest dose of the medications. But that, I think, by far is the one that we see the most of. Up to 50% of patients can have some of those side effects. And then there's some rare complications. I don't know if you want to take that.
Yeah, I think it's hard because in the lay literature, it's like anything else, things happen to people on these medicines. But the ones that we really know about in studies are the GI side effects and even gallbladder. Like we've had.
You lose a lot of weight, you get gallstones, right?
So in the studies, it did increase your risk of pancreatitis. So if you have one of those kiddos who has one of those mutations that puts them at risk, or very high triglycerides where you might worry more about that, we do avoid these medicines as well. The only other, the black box warning has to do with medullary thyroid carcinoma, but that's a pretty rare thyroid type of cancer. What you get is like any thyroid cancer in your family. Oh, my great aunt had a nodule out, and you're like, oh, I don't know, Sure. But these are inherited types of thyroid cancers in endocrine neoplasia syndrome. So they'd be able to tell you, like, yes, this runs in my family or not. But I think those are sort of the biggest proven ones.
And then I did want to bring this up because it's recommended that you don't take them during pregnancy. And for young ladies that have PCOS and maybe aren't menstruating regularly and you go on this medication, and you probably have heard in the lay literature, these Ozempic babies, like people can get really fertile if they lose some weight and their cycles regulate. So I think it is important to discuss that with your patients that can get pregnant, that, hey, this medicine might actually improve your fertility. So be careful,
That's a good reminder. That would not have been top of my list. And then what are your patients like tell you? Like, what's their subjective experience? How do they describe the feeling of these medicines?
I actually don't have kids complain about them a whole lot. The things that I've heard from people are that some people truly get joy from eating and from food, and they will describe that they lose a little bit of that, like especially if like they're out with their friends and they're typically going to hang out at McDonald's or I don't know, whatever plays, that there is a little bit of a social component to that. I don't think that's a huge barrier, but sometimes I do hear that. But I think a lot of times the kids are honestly relieved, that they felt this, I don't know, psychological weight. I hate using that word weight, but like they're just happy that, especially the ones who've really put in a lot of effort, to improve things and feel that frustration. By and large, I think they're well tolerated. But there are some people that again, like Stavra said, that just can't.
Not
the
even
GI
the
side
lowest
effects
dose.
aren't worth it.
Mhm.
I also have heard a couple people say they just feel wrong.
Yeah.
And they can't.
It can blunt your appetite to the point where you just don't think about food at all. And some people call that food noise. You're just not
Yeah.
thinking about food. So you really do have to make sure that they're eating regularly. But that can be, I think mostly adults have commented on that. I haven't had kids voluntarily say, I don't
think they use that word.
They don't use food noise,
No,
but that
they don't
can
use that
happen
term.
where they just forget to eat.
Yeah.
So it's important to make sure that they're not just eating one meal a day anymore,
Mhm.
that they're actually eating regularly. There's been some in the adult literature, like, depression and alcohol dependency going down, but I don't think we see that signal in pediatrics.
We don't think we've even studied.
We're probably not looking
that
for
kind
it,
of stuff.
but we haven't really looked at
Yeah.
if people feel more energetic
Yeah.
but I have seen patients who've tried for years to eat
Mm.
healthy and then they just are like, it's so much easier now that I'm on this
Mm.
medicine. I can make those choices without my body kind of fighting me back.
Mm.
And do you make recommendations to parents to make sure they're monitoring their intake, make sure they are eating enough? I mean, to the
Mhm.
point of like calorie counting, or more just a general gestalt of they're still eating?
Yeah, I think more just making sure they're still eating and they're eating the right things.
Good
Yeah.
quality.
Because good quality of food,
Mhm.
because if your appetite's really blunted and then you're eating 2 bags of Cheetos and that's your
Mhm.
entire nutrition for
Yeah.
the day,
Yeah.
then, you're not getting the nutrients, you need. So again, that dietitian piece and having that already set up,
Mhm.
it continues even on these medicines because you want to make sure they're putting good quality food in their bodies every day.
I've been using this angle because I'm really interested in this emerging literature of like what foods naturally stimulate GLP-1. And so one of them is fiber. So high fiber intake, it promotes your satiety, but maybe it's through these GLP-1 pathways because the bacteria that live in our gut actually metabolize these into short chain fatty acids, which that actually does stimulate one of these enteroendocrine cell classes of cells. So I'm kind of like really intrigued by this. Like if we can get them eating healthier, can we boost their natural GLP-1 levels? Like could people eventually taper down a little bit if they learn to eat different food? 'Cause a lot of our kids don't eat any of these. I feel like many of them barely eat fruits and vegetables and have very low fiber diets. So I don't know if that's very interesting to me is like, are there ways you can eat that maybe boost your own endogenous GLP-1 secretion?
Yeah. It's so hard because
Yeah.
there's definitely like, socioeconomic barriers in this whole
Yeah.
conversation, right?
Sure.
So again, fresh fruits and vegetables are expensive and sometimes people don't have access to those. So I think again, it's really like working with the family and their own budget and their own like ability to, to do these things. But, so it's why it's like the hill I'll die on. There really is no one size fit all of like how you hand down, these sorts of things. But I think these conversations are really important.
And then maybe budgeting extra time if you're going to do this in your clinical practice so you can have some of these conversations. If you can, I think it's really great if you can have a dietitian address some of the nutritional aspects. But I think if not, it's really important to schedule a little extra time to talk to these patients in depth about these things. It's difficult to do in a short visit.
Sure.
Mm-hmm.
And then, Nancy, I think you had mentioned losing muscle mass.
Yeah.
So what's the role of, prescribing exercise, whether it is weightlifting or aerobic exercise, like how important is that?
Yeah. And again, I think exercise traditionally is thought of like what you do to burn calories and like lose weight. And I'm not saying that's not a piece of that, but in these conversations for me, it's muscle is metabolically protective. It protects against all the things, diabetes, liver, cholesterol, all the things. So, anytime you lose weight, especially if you lose weight rapidly, you will lose muscle mass. And so we want to protect that. And so making sure they're getting good protein sources and doing muscle building, strength, building. We should have you lead a class now. But anyway, exercise is really important to protect that muscle mass. And then again, these tools that you have in clinic that will look at body composition help reinforce that you're protecting the right part of your body as your weight goes down.
I think everything's so intricate too. So it turns out your muscles release myokines, like these circulating chemicals or hormones. I don't know if they're hormones, but anyway, the myokines communicate with these enteroendocrine cells again to stimulate the release of some of these hormones. So I think it's just kind of cool for me to see like all of these things we've been telling people to do because of health and are actually all communicating with each other to maybe regulate your entire GI endocrine system and how it communicates with your brain. So yeah, another good reason to exercise is it may also help promote your natural kind of GLP-1 levels like to go up. Mm-hmm.
And then the last thing I want to talk about today is barriers that you guys have encountered, whether it's financial barriers, the fact that it is a shot that they have to self-administer or parents administer. So can you guys talk a little bit about the barriers to accessing this care that families have had and what kind of things you found to have more success?
I think the biggest one is cost, hands down. And then just whatever insurance coverage or patchwork system that we have. So it can vary a lot state by state, whether Medicaid covers it, personal insurance companies vary, and then it can change. So you might be approved for a year and then all of a sudden they change their minds. So that I think is really difficult for us and families to navigate.
Yeah, I think so. I do have kids who are terrified of needles. Like
Mhm.
they just aren't going to do it.
Mhm.
Multiple drug companies are in the process of developing oral forms of this medication for a couple of reasons. One, they're going to be cheaper. Anytime you make an oral therapy, it's cheaper than an injectable therapy to manufacture and distribute. So I think this world's going to change a lot where the cost won't be as big of a hurdle. I also think the oral ones haven't been shown to be as effective, but might be a happy medium. And then I think, certain companies have embraced direct relationships with that company to provide the drug that's cheaper. So those things, again, I think are going to continue to evolve. But it's really frustrating because I've had kids where I really think they would benefit so much. You've seen these kids with me sometimes, metabolically, and we can't get it. And then someone, and I'm not saying it's more or less than, please don't think I'm saying that, but then someone who doesn't have those complications, who just is really frustrated about their weight, can get it easily. And it's hard, I think, to be a physician and have that dilemma where you can't help your patients equally because of a factor you can't really control. But Stavra had mentioned this before, but you really need office staff who know how to do these PAs. Almost nobody's just going to give it to you without a PA.
There's a lot of behind the scenes.
So and they want you to state like what the lifestyle plans are. A lot of these insurance companies will approve them with but those are hard letters, to write. And so we do have some standardized ones, but you want to make sure that you're putting best effort forth to try to get them when you feel like they're warranted, but it is effort.
And I do feel like sometimes trying again a year later because things can change. And then sometimes just proving that they have an approved comorbidity can help, even off-label. Like I've had some young people recently with the approval for treatment of MASH in 18 years and older. I've been able to get some off-label approvals for some of my adolescents with proven MASH, with fibrosis. So that sometimes helps. And then just a word of caution, a lot of people sometimes turn to these companies that sell these
The compounding pharmacies. I was going to ask about that.
Yeah, the compounding. And I think we are hesitant about that because you don't really know what you're getting when you get a compounded medication.
Yeah.
I don't know if you want to say more about that.
I
we can file this under opinion.
Yeah, file this under opinion. I personally won't write prescriptions to compounded pharmacy because I just don't feel like they're regulated in children. If adults want to make that decision for themselves, I guess, great. But there's been some bad outcomes of people not mixing them correctly or drawing them up. And so I like these pen devices. So this microdosing, right? Yeah. It's like a pen device where it's a safely delivered FDA screened medication. I just, as a pediatrician, feel better about that. But I kind of feel for these families too, because a lot of times the moms have gotten them. It's usually the moms, sometimes the dads. I don't want to be sexist about it, but they've had great success on the compounded ones. And now they're asking for that for their child because the insurance won't approve it. And it doesn't feel great. So I mean, I have that conversation, but I think it's just really challenging to navigate. And I am kind of excited that these orals will eventually, I'm confident they'll come out for kids eventually because
it's oral.
That'll be something a child is more likely to want to take than an injection, and will be easier to afford, I think, for families who can't get insurance
coverage for them. Do you think there's tachyphylaxis to these medicines? You know how the GI side effects get better. Do you think there's like a weight or a metabolic tachyphylaxis?
That's an awesome question. Because we see these plateaus anyway, right? With like weight and even metabolically. Like there's some people whose beta cell defect is so strong. Like I can give them the best diabetes meds in the world. They're always going to have some degree of that. So that's a great question. I don't know that we know.
Like, will the efficacy become less over time? Because we see that with the GI side effects. So it makes me wonder if in some people, I do have some patients panic sometimes. They're like, I feel hungry again. What's happening?
Yeah,
like I wasn't feeling hungry and now I feel hungry again.
No, you're right. She's right. You will see that. And then a lot of times it's when I go up on the dose if they're not a max dose, but you could
And
very
then-
well be right. Or there's social cues or
Yeah.
other things that are kind of coming back, even though you're on.
And then I don't think we have good guidelines about how to taper people down. So maybe
Mhm.
some people could taper down once they've gotten to where they need to be on a lower dose, or maybe you need a little bit of a holiday so you get the effect again. I don't know. These are
Mhm.
all completely unanswered questions.
And even in
Um,
they're not answered in adults,
Yeah.
right? And so of course you know how this works. It's
Yeah.
always like adults
Right.
first,
Yeah.
and then we get brave
Yeah.
enough, because we do want to protect kids, and we don't know what it means to be on a medicine from, say it's approved at 12 to 70 years old, years of age to be on. We don't know that. We're not going to know for a long time, but certainly the studies up till now don't make me nervous about
No.
prescribing them.
And I don't think primary care physicians or providers need to worry necessarily about learning how to do this. Like, I think this is very much something you could do in private practice, but you need to make sure you do it safely
Mhm.
and you provide appropriate level of support. So it's not a prescribe this medicine and then see them back in a year.
Sure.
That's, I think, the important message I think I want to say.
Yeah, what
Yeah.
I've told my pediatrician friends is have a person or two people in the group who really take this on,
Yes.
because the science is changing pretty rapidly. The medications are changing
Yeah.
rapidly. It's a lot to keep track of, and you want to make sure you're doing it the right way, and then you'll know the ins and outs of getting
Yes.
them approved, the labs,
Mhm.
when you do need to refer. So to me, it's not something that you would ask, PCPs across the board to do the same.
No, I
any-
agree. I
you know,
agree.
any more than I'd ask you to treat diabetes.
No, you need to become well versed in these class of medications, stay abreast of what's
Mhm.
happening, and make sure you have RD support, ideally
Yeah.
a way to measure body composition in your office. I think that's the safe way to do it.
And if we do have questions, who would you recommend that we call? Is it more endocrine? Is it GI?
I mean,
Does
I
it
think
depend on your
it's-
community?
It's
support?
multidisciplinary. So I think endocrine's always a great place to start because they've been using these medicines the longest, right? You guys have a track record with
Yeah, but I
diabetes.
mean, really, each hospital and location does this differently. Like, we have this weight management
Mhm.
program that also prescribes
Yeah.
these medicines, and those are general and academic pediatricians who've really taken, obesity management on as their main interest. That's literally all they do. But then some systems, endocrine does all
Yeah.
that. Some systems, GI does all that.
Well, and I'll say the vast majority of us have pursued additional training in obesity medicine,
Mhm.
which is relatively it's attainable. You take some additional CME courses, you take an examination, there's continuing education components, but that was for me super important for me to feel comfortable kind of delving into this, and that's something I would highly recommend if you're interested in this. There's different associations, Obesity Medicine Association, there's many.
Yeah. You don't have to do a fellowship to
No,
be
you
obesity
don't.
board
Yeah.
certified. It's just CME that you can buy or go to conferences to obtain, and then the board's fee.
Right.
Yeah, there's a financial component there.
There's always a fee for appropriately. I'm not, but in any case, yeah, that's something that, again, a PCP could decide that they want to do this and be that person, or the group support a pediatrician to be that person who gets board
Yes.
certified and really stays up on it, and using things like consulting fees and not just thinking of it as like a medical,
Mhm.
medical only component of their job.
So again, we don't want to gatekeep and say you have to be, sitting in a large academic institution to do this, but we just want to make sure everybody's doing it safely for the patient.
Of course.
Yeah.
Well, Dr. Xanthakos, Dr. Crimmins, thank you guys so much. I've learned a lot today. For our listeners, today's episode is available for CME. You can find the link to that in the show notes, and I hope everybody has a good rest of their day. Thanks, guys.
Thank you very much.